be published 4 times a year. It's now published every month. So again, trying to make sure that information is as up to date as possible. And we have reviews that will be published, I think, on the 9th of September. They haven't been published yet, but we've put in the biggest portfolio of reviews that we ever have this month for publication, and include just some very diverse topics. Cervical pessary for preventing preterm birth. This is, instead of putting in a suture in the cervix, using a pessary to try and keep it closed. Corticosteroids for HELLP syndrome, a variant of preeclampsia where corticosteroids might or might not help. Different regimens for treating asymptomatic bacteriuria, which we know can be associated with a number of bad outcomes, including preterm birth. Different targets for treating women with diabetes, how rigorous should be the control of the blood sugar. Interventions for nausea and vomiting, an enormously common problem, as you know. Hyperthyroidism, peripartum cardiomyopathy, which is a very rare problem but is associated with a high mortality, a high risk of death. Parenteral opioids, enormously important topic. Treatments for breast engorgement during lactation, and the use of Doppler ultrasound during pregnancy. So very diverse topics, but some really important ones. These reviews will appear in the next week or so. Also, as I've mentioned, the importance of updating reviews. This is actually a major challenge. From the outside, people think it's quite an easy process, that somebody writes a review and then looks to see if there are additional trials being published, and then put the trial data in the review and update it. And sometimes that's how it works, but often it's much more difficult than that because of the improvement in the statistical methods. Actually it can be quite challenging for review authors to bring a review up to date. But again, there's some important topics have been updated. Ellen Hodnett again, alternative versus conventional institutional settings for birth, and this is a very contentious, controversial area, as I'm sure you're aware at the moment. So that there's a spanking new update about to appear in that. Pulse oximetry during labour, magnesium sulfate versus lytic cocktail. Lytic cocktail is a treatment that was used very much in India for treatment of eclampsia, and again we try and make sure that the topics are international and address international issues rather than just local issues. And surgical procedures for evacuating incomplete miscarriage, again an extremely common, important problem. So the logo of the Cochrane collaboration, what it shows is 2 C's for Cochrane collaboration, but it shows in the middle a forest plot, so a meta-analysis, and the meta-analysis is what the evidence of the use of corticosteroids before preterm birth would have looked like had a meta-analysis been performed in 1981. And in fact, it wasn't done until 1989 for the first time, but way back in 1981, these are the different trials, and this is the pooled statistic, which showed a statistically significant reduction in the risk of death in newborn babies after preterm birth. So the information was available about 10 years before it was formally synthesized, and as a result, thousands and thousands of babies died, in fact unnecessarily. And the corticosteroid story is interesting as an example of translational medicine. There's a lot of talk about translational medicine at the moment, getting results from the lab into the clinic. And it started with Montliggins, an obstetrician and physiologist in New Zealand, and his colleague Ross Howie, who was a neonatologist. And Montliggins was interested in understanding what caused labour, what was the physiology of labour, and the experimental animal that was used in fetal physiology work for all sorts of reasons was the sheep. And he noticed that if he gave the ewe injections of corticosteroids, they did deliver early, but the fetal lambs that were very premature, in fact, breathed at a time when they shouldn't really have been able to do that. So it was that observation that was taken into initial trials, and the review was the Cochrane review was originally produced by Patricia Crowley, working in Dublin, but was updated fairly recently by Stuart Dalziel, who's a neonatologist in New Zealand, and my colleague Devinder Roberts, who's an obstetrician in Liverpool. And again, reinforced the findings that corticosteroids are good before preterm birth, and confirmed that neonatal death was reduced, respiratory distress syndrome was reduced, as was intraventricular hemorrhage, but also found that necrotizing enterocolitis was less common after steroid treatment, as was infection. So this was a really important review, but one that had been out of date for quite a time, but which has now been updated again, and with some novel findings. But there's a difference between identifying evidence and getting evidence into practice. And we had a PhD student from Thailand who did some work with us about 5 years ago. And she did a survey of obstetricians in Thailand through the Royal Thai College, and the obstetricians really all said that they would give women corticosteroids if it seemed likely that they would deliver prematurely. But as part of the project, she also looked at what was happening in one province of Thailand. So this is not the people that were surveyed, but a different group of clinicians working in a different part of the country. And what she found was that in practice, really about a quarter of women who had premature labour, in fact, were receiving the benefits of corticosteroids. So it is still this difficult challenge of getting evidence into practice. And the main mechanism for doing that is through guidelines. Now, really there's been very, very little positive happened in the area of preterm birth since the corticosteroid story first emerged. And preterm birth is still the major perinatal challenge that we have, with the risk of death and all sorts of morbidities associated with it. So I just wanted to share with you something which I think is quite exciting, which is really just emerging this year, and that's the question of whether magnesium sulfate is a useful treatment for women who seem likely to deliver preterm. And where this came from was that magnesium sulfate, as you know, we use to treat eclampsia and women with severe preeclampsia, but it's also been used extensively as a tocolytic drug in the United States. And it's a very poor tocolytic drug. It's not good at suppressing preterm labour. But what emerged was from a case control study was that children who, as fetuses, had been exposed to magnesium sulfate before preterm birth were less likely to develop cerebral palsy later in childhood. And there are all sorts of potential biases to that type of observation, but it provoked a number of randomized trials, which have now been summarised in a Cochrane review by Lex Doyle and colleagues from Australia. And what it shows is that the risk of death or cerebral palsy is reduced amongst the babies whose mothers received magnesium sulfate, as is the risk of cerebral palsy as well. And the theory is that the magnesium sulfate has a protective effect on the vulnerable brain of the preterm baby. So this is potentially quite exciting. So the authors were able to do a numbers needed to treat calculation, and found on the basis of these trials that 53 women with preterm labour or likely to deliver preterm would need to be treated to prevent one case of cerebral palsy. And the implications of cerebral palsy are such that that actually seems a very good ratio indeed. So the Australians have earlier this year, on the basis of this Cochrane review, have introduced guidelines recommending that magnesium sulfate be given to women who are thought likely to deliver at less than 28 weeks. So that's one exciting development. Just wanted to mention a few other innovations. The use of individual patient data meta-analysis. So most of our reviews are based on what are called aggregate data, taking the data from published trials, but it's possible to actually get information about all of the in our case, women who have been recruited into trials. It's a much more complex and resource-intensive way of doing a review, but it is possible, and it allows much more sophisticated assessment of subgroups. Screening and diagnostic tests. So this is a departure from just looking at randomized trials, but looking at whether diagnostic tests predict the outcome that they're supposed to do, and I'll show you an example of that. Overview of reviews. The problem with the attraction of overview of reviews is that if you're interested in a particular topic, say the assessment of the fetus during labour, that there are maybe 10 different reviews that you would need to look at, and there isn't a publication that brings all of those data from the 10 reviews together, and I'll mention briefly an example of that. And also the linkage with clinical trials. So individual patient data meta-analysis, this is one of the few that have been published, very few that have been published in our area, which is antiplatelet agents like aspirin for the prevention of preeclampsia. And this has been done by Lisa Askey in Australia, Lilia Dooley, who's one of our editors, David Smart, who's also a neonatologist from Australia, and shows that aspirin does, in high-risk women, does have a modest but statistically significant effect in reducing the risk of preeclampsia. Screening and diagnostic tests. We've been involved in a project looking at the different methods of screening for fetal Down syndrome during pregnancy. And this turned out to be a much more difficult project than we had anticipated at the beginning. Methodology is quite new, which is part of the problem, but there's also a huge number of publications. And it's an area where there are kind of commercial interests as well, and some of the publications are a little bit opaque, and it's a little difficult to understand where the findings in fact come from. But it's something that we're still working on at the moment, and there's now software that allows us to generate this type of chart. This is a receiver operated curve, specificity, sensitivity. So the perfect diagnostic test would be up here. Identifies all of the condition that you want to identify and doesn't have any false positive results. And these results are for a formula including maternal age, nuchal translucency measurement with ultrasound, and some biochemical tests. But this type of chart allows you to compare different methods of